Let's quickly talk about the different red cell morphologies that can be seen as poikilocytosis on a normal red cell smear or may be related to a disease process. So first, here's an example of a diagnosis of hereditary spherocytosis. And in this example, we can see here even in our zonal morphology, there are quite a few cells without any central pallor and are perfectly round. These are the definition of spherocytes. They can be seen very rarely in a normal peripheral blood smear, but when they're seen this many in a single field, we have to consider a diagnosis of hereditary spherocytosis. Typically, these patients will receive a splenectomy at some point in their treatment, and therefore these patients may develop signs of hyposplenism, such as Howell Jolly bodies, target shaped cells, and thrombocytosis. Hereditary spherocytosis is typically caused by a defect in membrane stability. Typically, this is a deficiency of spectrin, but can be a deficiency in some other skeletal protein. Another example of a red cell membrane disorder is hereditary elliptocytosis. So here's an example of hereditary elliptocytosis. At high power, we can see that nearly all the red cells show some sort of elliptocyte shape. This is not to be confused with the elliptocyte seen in iron deficiency anemia. Although similar, the number of elliptocytes in hereditary elliptocytosis is markedly increased in comparison to those that are seen in iron deficiency anemia. Again, a defective spectrin is the most common abnormality in hereditary elliptocytosis. Hereditary elliptocytosis also shows an autosomal dominant inheritance pattern. Typically, the elliptocytes will make up 70 to 100% of the red cells, but even in some cases, the elliptocytes may represent only 25% of all red cells. Since hereditary elliptocytosis is often asymptomatic, the diagnosis is frequently made incidentally. A mild degree of red cell fragmentation due to the red cell shape may lead to a mild anemia in some cases. Here we'll show an example of a case of myelofibrosis with increased dicryocytes, or increased teardrop-shaped red cells. So at high power, we can see that a number of these red cells show characteristic elongation of one side of the red cell with a tip at that side. And so these are appropriately named teardrop-shaped cells or dicryocytes. These can be seen artifactually in cases where the peripheral blood is smeared aggressively over the slide. In these cases of artifactual dicryocytes, all of the teardrop shapes will be pointed in the same direction. However, in this case, we can see that the teardrop-shaped red cells are all pointed in separate directions, indicating that this is not an artifact of the smear preparation. Here's two really good examples of dicryocytes. I like to think of dicryocytes as being forced out of the bone marrow prematurely. So they get pushed and squeezed out of the bone marrow and they're not ready to leave, and so they try and hang on as long as they can, and that's the little teardrop shape that we see in the peripheral blood. In this case, the teardrop shape is because of myelofibrosis in the bone marrow. The red cells are being squeezed out of a fibrotic marrow. Other times that you can see dicryocytes is when there's tumor infiltration of the bone marrow, when there's overproduction of some other cell in the bone marrow, and, as with this case, in fibrotic processes. Rare dicryocytes will be present in a normal peripheral blood smear. However, when frequent dicryocytes are seen in the peripheral blood, this can be an underlying pathology within the bone marrow. Next, we'll see an example of codocytes, or target-shaped red cells. So here at high power, we can see many of the red cells show target-shaped morphology. In this example, the codocytes are due to liver disease. However, target cells are created when there's increased surface membrane to volume ratio. This may be caused by more membrane than normal due to excess lipid deposition, as seen in liver disease, as in this case, or less than normal loss of lipid during maturation of red cells, as seen in post-splenectomy states, or by decreased or abnormal hemoglobin content, as seen in thalassemias and hemoglobinopathies. When the target-shaped red cells are microcytic, consider thalassemia and hemoglobinopathy at the top of your differential. However, when the red cells are macrocytic, this is generally associated with liver disease. Of note, target-shaped artifactual change has been associated with air drying artifact, as well as due to excess EDTA anticoagulant. Next, we'll talk about echinocytes. So as we find our zonal morphology, we can see at high power that many of the red cells show short and often blunt projections over the entire surface of the red cells. As we zoom around, we can see that many of these echinocytes have these blunt projections that surround the entirety of the red cell. There are also some areas where the blunt projections become pointed projections, and this is a different cell type that we'll talk about next. A number of different artifactual or environmental conditions, such as pH, albumin concentration, among others, may transform the red cells into echinocytes. The most common cause of true echinocyte formation is an artifact of smear preparation. However, clinical conditions associated with the presence of true echinocytes in peripheral blood include severe renal disease associated with uremia, liver disease, vitamin E deficiency, pyruvate kinase deficiency, burns, heparin therapy, and gastrointestinal disorders. In this specific case, the patient has end-stage liver disease as well as a acute kidney injury. In contrast to echinocytes, acanthocytes are spheroid red cells with spiny projections that are irregularly distributed over the surface. There is no central pallor as seen with echinocytes, and the presence of a large number of acanthocytes may elevate the MCHC. Acanthocytes form due to the alteration in the lipid content of the red cell membrane. Accumulation of either sphingomyelin or cholesterol is often the cause of acanthocyte formation. Acanthocytes do not deform as readily as a normal red cell, and as a consequence are often sequestered in the spleen and destroyed. Clinical conditions associated with acanthocytes include A-beta lipoproteinemia, hypo-beta lipoproteinemia, and advanced liver disease. Mild to moderate acanthocytosis may be associated with a post-splenectomy state, vitamin E deficiency, malnutrition, or myeloproliferative disorders. Some laboratory tests to evaluate when seeing acanthocytes is to check liver function. In this specific example, we can see evidence of hyposplenism, including here 3 Howell-Jolly bodies, and increased poikilocytosis. And lastly, we'll look at quote unquote bite cells. So at high power, we see rare cells which look as though they've had a bite taken out of them. These are classically related to the removal of Heinz bodies by the spleen. Heinz body formation is the result of oxidative stress to hemoglobin by either drugs or denaturation of unstable hemoglobin. The bites can range from tiny nibbles to almost 1/3 of the cell. Clinical conditions associated with the presence of bite cells include acute oxidative stress in G6PD deficiency or other enzynopathies, unstable hemoglobin disease, overdose of oxidant drugs, as seen in this case with an overdose of dapsone, a common cause of bite cells in our patient population, and can occasionally be seen in some thalassemias or with severe liver disease. So as we move around, Please note the different morphologies of these bite cells. In this case, the bite cells are relatively subtle, but we do see them in nearly every field. And lastly, we'll talk about schistocytes, or true red cell fragments. So as we find our zone of morphology on this case of microangiopathic hemolytic anemia, we can see even at 50x that there are numerous red cell fragments. So let's take a closer look. So at 100x, we can see numerous cells that appear as though they were once red cells and now have been taken and sheared. Here's a very good example of a schistocyte in the center with a triangular morphology. When you see a red cell with 3 distinct points, that is a clear and distinct schistocyte. Schistocyte technically is defined as any red cell fragment. However, it is difficult sometimes on morphology alone to identify a red cell fragment from, for example, a bite cell. And so when you see a red cell with 3 distinct points, you can definitively identify that as a schistocyte. And in this case of microangiopathic hemolytic anemia, we see numerous schistocytes. Here's another really good example of a triangular form of a schistocyte. Red cells show fragmentation when they're damaged by any of the following factors: fibrin strands blocking the lumen of microvasculature, shear force injury due to high blood pressure, mechanical pressure such as crush injuries, the surface of implanted prosthetic valves due to heat, oxidant stress, certain intrinsic red cell defects can all cause red cell fragments. Clinical conditions associated with the presence of schistocytes in the blood include thrombotic thrombocytopenic purpura, or TTP, hemolytic uremic syndrome, or HUS, disseminated intravascular coagulation, or DIC, HELP syndrome, which is characterized by hemolysis, elevated liver enzymes and low platelet count, severe burns, prosthetic heart valves, malignant hypertension, metastatic carcinoma, septicemia, certain hemoglobinopathies, certain red cell membranopathies, certain red cell enzymopathies, and a disorder called March hemoglobinuria, which can be caused by excessive marching, which is typically only seen in military personnel.